Okay, you are. Okay. So thank you very much, GeekyAnts, for giving us this nice opportunity to share our experiences in healthcare and specifically when it comes to interoperability. We are basically a practice management solution company. We have a product around practice management, and we also have an EMR component inside the practice management that are being used by hospitals as well. And we have a patient health record application as well. And built into all this is a teleconsultation module. Okay. Now, when we worked on these projects and these modules for the past 6 years or so, we have come across many use cases of why systems have to be interoperable, especially when it comes to larger hospitals and entities that are larger than clinics. Okay, but there are use cases that are specifically for clinics as well, which we will touch upon. So today's presentation is going to be more overview of what is interoperability and what are the issues without interoperability, what are the issues, what are the benefits of using interoperability, and how do you achieve interoperability, what are the standards. Okay, and a glimpse of how these standards look at glimpse of how these standards look, and also a few use cases of how we used interoperability in some of the situations that we encountered in our recent past. Okay. Um, so if you post this, I've kept a little bit of time for any questions and answers. We can address any specific questions about what we talked about today. Anything out of the scope, you can always reach me. You can look at our company's info at www.palmpower.in, and my mail ID is ravi@palmpower.in. You can also send me a mail if at all you have some questions about what we talked about today or even otherwise. So the official definition of what interoperability is the ability of a computer systems and software to exchange and make use of information, right? So here we are talking about computer systems, we are all talking about software, we are talking about exchange of information, and we are also talking about making use of this information in a meaningful manner. Okay, these are the main components of why we need interoperability. So, problems that you will face if you do not have interoperability are these. Okay. So, it all started with unwillingness to share information, right? So, software companies that have been early in the market with respect to healthcare, these are like larger corporations. Okay. They got on to the opportunity much, much earlier. When it comes to EMR and healthcare software systems, probably we are like 30 to 40 years behind the leader, which is the United States. Okay, but there's a good side to it, okay, because we can always learn from them and leapfrog in terms of technology, which is what we have done in the other segments like finance and telecom as well. Okay, so we jumped right to 3G and 4G, skipping the CDMAs and 2G revolution that happened in the United States. Similarly, here in healthcare, there is something that's happening which we will touch upon briefly, but there are other people talking about it, so I wouldn't take much time about ABDM, which is what is happening in India. Okay. Then the second issue that we have is corporate wanting to monopolize information. Okay. When the corporates hold the patient information, okay, now they indirectly hold the customers to themselves. It is not a bad thing, but the problem is that if the customer wants to switch their provider, so it becomes very difficult. So when there is interoperability, switching over is easy and sharing is easy. And when it comes with the government mandate, it becomes much more easier to share information, and it becomes law of the land, so that everybody has to share information. Okay, this is what happened in the United States. It has not happened in India yet, but it is likely to happen in the near future. Okay. Early on, whoever is innovating, okay, they just innovate based on what they know, what the situation demands. Okay. But as we progress in innovation, at right time there has to be some standard that needs to be set, so that interoperability becomes a norm instead of an option to do it. It should become a norm. In many areas we have seen interoperability. For example, if you take UPI in India, the government has created the National Payment Corporation, and everybody had to adopt to a particular set of APIs that the government set. And now you have many UPI applications that stick to that standard, and people can switch from Google Pay to Phone Pay to anybody else. Okay, without any worry at all. Okay, so in healthcare, it has still not happened. It has not become that seamless yet, but then it will happen. So there are efforts that are going on by the government. Government also has come up with an infrastructure. It has come up with an API, and there is no strict mandate as yet. It is optional today, but then it will definitely happen down the road. Okay. So when you have interoperability, okay, then cost of migration and adoption, okay, will become easy. But without it, it becomes very difficult. You are stuck with one provider of software. You're stuck with a set of a set of non-standard applications. Okay, so moving away from any of this kind of software is going to become difficult, and it will also become very expensive. Okay. So early adopters would have created legacy systems. Now, if you have a standard, at least you can write a small plug and play module which will adopt the standard on one side. On the other side, it will give interface to the legacy systems as well. So having a standard always gives a benefit. Okay. And having standards is the key foundation for interoperability. So as I told you, the advantages of having interoperability is the freedom of choice. Okay, I can choose any vendor, and if I don't like, I can switch over. So this is the main criteria for any of the large corporations to adopt a standard-based, software, technology or software. Okay. Freedom to switch and freedom to choose. Okay, these two are, you know, once you once you choose, okay, you should also have ability to switch. Okay, so having an interoperable system gives you both, and it also gives you much cost advantage in terms of running costs, because if you adopt to a standard, you can plug and play easily different systems. For example, in a hospital information system, you can have a billing system from one vendor, you can have an EMR from another vendor, and you can also have inventory and lab and pharmacy. They will all have their own systems, and it will also give you a real good feature benefits as well as cost advantages. And also having standards and interoperability give you ability to analyze the data electronically. Okay, without that, each one of them will be having their own masters. Each one of them will be having their own codes, and it become a nightmare to make meaning out of any of this data. So interoperability gives you these big advantages. So in the healthcare, when we were implementing our application in clinics and hospitals, we have come up with these kind of scenarios that demand interoperability. Okay, a doctor wanting to share information with another doctor or another facility. Okay, that is within the facility they want to share. Okay. A doctor wants to share across facilities. For example, a hospital like Vedanta or Aster or Apollo, they are all having multiple centers. Some of the centers are specialized centers, So from one specialized center, you want to move a patient to another specialized center. Okay, how can you move the patient's information? Okay, seamlessly. Okay, this is another scenario that we have encountered recently. An intra-facility, for example, you know, Aster Hyderabad wants to share information with Aster Cochin. Okay, and some of the cases, what has happened is that when you are talking about the same organization, let's say Aster, but they are having two different centers, the same software provider has given the software, but they are of different versions. Okay, so it becomes difficult to exchange information in such scenarios. But we have overcome these limitations. But I'll tell you architecturally how we have overcome this situation. Now, interfacility using the same software with different versions from the same vendor is what I explained to you just now. The other scenario is interfacility using different software vendors. The doctor wanting to share information with patient, doctor wants to share information with other providers. For example, the doctor has written a prescription and he wants to share it with a lab, or he wants to share it with another, let's say a pharmacy. Okay. Patients wants to carry their information so that when they are traveling abroad, okay, if there is a standard, if they are carrying their information, then it becomes easy whenever there's an encounter. And patient also today wanting to share information with other providers like pharmacies. For example, if they want to buy something, okay, how can I share the prescription written by a doctor to the pharmacy? Okay. So these are the broad use cases that we have come across when we are implementing systems. Okay. Now, when it comes to standards, okay, so there are different classes, okay, of what the standards comprise of. One is the big messaging standard. How do I communicate with another system? So there are protocols developed, in HL7 messaging. Okay, so you have things like, okay, how do you handshake? How do you exchange information about your capability? And how do you send heartbeats so that two different systems know that the other systems are working. Okay, so these are messaging standards. Then we have data formats, a standardized way of exchanging information. And then there are nomenclatures like a parlance, and then a syntactical way of expressing certain information. For example, how do you say that the patient is having cold, or how do you say a patient is having a knee joint pain on the right hand side, on the right knee? Okay. These are a standard parlance and a specific way of communicating both electronically as well as verbally, okay, among practitioners and providers. So the predominant standards in healthcare are the following. Okay, we have HL7, which also has a communication piece of it, and it also has a data format. So if you look at the slide, HL7 started in 1987, way back, and they have come a long way, and it is still predominantly used between machine-to-machine communication, because there are so many machines that came into the market, probably 10 years ago, 20 years ago, even prior to fire, they still use HL7 communication uh, data formats, and they're not going to go away anytime soon. But then we also have fire, okay, which is the fast health interoperability resources, which is much more readable, much more structured, easy to modify, easy to add. Uh, Basically, these resources are JSON structures, and you can also have XML structures for fire, but then what I have seen is predominantly JSON is being used. We also have the clinical document architecture, which is predominantly used for doctor to patient and patient to doctor exchanges. So there are applications that creates CDA documents, put it on, let's say, a removable drive or a pen drive, and you can carry it and then use it whenever is necessary when you're traveling, right? Then we have Snowman CT. Okay, this is predominantly used for basically providing a clinical terminology. How do you say that the patient is having fever with chills? How do you say the patient is having glaucoma on the left eye? When these are standard based clinical documentation. Then we have Loency, which represents, this is a standard to represent your lab results, and the lab values, like how do you say what is the CBC count? Okay, how do you say NMRA terminology? I mean, these are um, clinical terms for lab results. Then we have ICD, which is basically a disease code. Okay, from ICD 10, the world is slowly moving to ICD 11, but they are also making these two interoperable. These are basically disease code, which are basically diagnosis codes and also procedure codes. Then we have NCPDP for exchanging prescription drugs, and finally we have DICOM for imaging standards. So this is how an HL7 data looks like. Okay, it's very cryptic. Making meaning out of it just by looking at it is going to be difficult. You need to really understand this format to make sense out of what it is. But then it's been predominant, and it is currently even currently used in machine to machine exchanges predominantly. Compared to HL7, this is how the fire data looks. Okay. And what I've represented here is in JSON format. But as you see it, okay, you can make some sense out of it, right? So that is the biggest advantage. But it looks a little, verbose and heavy. But then if you use compression, this can get really compressed to a very small size for information exchange. So the size will not be a problem, but I'll show you an example. It really looks very verbose, but when you use compression, this may not really be a problem. Okay, but then the advantage is when you look at it, you know what it is. So the SNOMED CD advantage is that it's a very structured information. So there are concepts and there are hierarchies. It starts from body structure, going all the way to what are the specimens, what are the scales, and it is a completely structured information. And they also provide relationships. They also provide attributes. For example, like whatever is given here, if it's an arthritis is also an orthopathy of a knee joint, which is also a higher classification of arthropathy. And then we have, it's nothing but a finding of a joint on your leg joint. When you say leg joint, it is also part of a musculoskeletal system. And on the top it says that it's a finding by a body structure or a body site. Okay, so then there are many relationships that you can build over this SNOMED CT database. So you should be able to find things like, okay, give me all the problems that are associated with that is arthritis, okay, or give me all the issues that are related to a knee joint. Okay, so these are relationships that are built over SNOMED CT database, and you should be able to query it and get relevant information as and when needed. It's a pretty structured information, but it is also complex to understand. Okay, so the complexity needs to be reduced to a great extent by the software providers to make it easy for the doctors to adopt it. Okay. And that is one of the things that we do in PalmPower. So ICD-10 codes, okay, looks like this. Okay, there are classes of codes. Okay, when you say C00 to D49, they all represent neoplasms. And then when you say E13, okay, it relates to diabetes, and it's a diabetes mellitus. So these are all classified codes, and these classifications are predominantly used for communication between providers and payers. most of the systems for insurance uses ICD-10 code for processing. Now coming to architecture, okay, so I have given some 3, 4 architectures here. Two of them are something that we have used in the past, and one of them is this. Okay, so this is a communication infrastructure between two centers, okay, of Aster hospitals. And what happens here is that there are two centers, one on the left hand side, which is the Aster MedCity Hospital, and on the right hand side, which is the Aster Kannur. Okay, the piece in between is our application that provides the interoperability. Okay, and all communications happen over VPN for security purpose. And one doctor sitting in MedCity in Cochin will be able to access information from another doctor who was created for the same patient sitting in Kannur. Okay, and what we have done is we have used a central server that provides communication. The central server is located in Bangalore, whereas these two servers they are sitting in their respective center, one in MedCity and one in Kannur. Okay. Looks like my 20 minutes is over. I will try to squeeze the other slide as quickly as possible. Can I take 5 more minutes?
Yes, sure. Yes, sure, you can take.
Okay. So here, this use case is where it is again multiple centers, but then one center is using one provider and another center is using another software provider, but the second center is using a HL7 standard, but the first center is using their own proprietary standards. Okay, so what happens here is if you really look at the difference between the other two, now there is a center, there is an in between piece that is sitting here. Okay, so this is an HL7 endpoint provider. This is what we call it as these are all adapters, and the adapter's job is to translate. Okay, from one format to another format and vice versa. But then imagine if there are 10 such providers, I'll have to sit and write 10 such adapters. Okay, and obviously we are going to charge the client for it, and obviously there is a acquisition cost for the client. Okay, but then if all of them are HL7, then it becomes a plug and play. Okay, so here, this is another piece that we have written. This is called a health locker. This holds information, who shared information with whom, for how long, okay, and how long it's valid, okay, who can have access rights, and stuff like that. Okay. So this is another use case that we predominantly use whenever we go to our clients, and to make them comfortable that even though you have disparate systems, we can make systems communicate with each other. So this is more of a US use case. This is a health information system, which I'm sure Ruben will cover. I will just give a very small overview. So there is this middleware here, and these are the providers, and each provider having their own repository. And then these are the users. Clinic 1 wants to use some data sitting in repository 1. Clinic 2 wants to use some data sitting in repository 2. And the central piece is the one is doing all the translation, like how I showed you the other just before. Whatever I showed is something similar, not exactly the same, but just something similar. So this is our ABDM. Okay, so we have, I would say that we have leapfrogged here as well in terms of learning from others and adopting something that is better, taking the advantage of the best of everything. Okay, so the centerpiece here is the ABDM gateway. Okay, This is owned by National Health Authority, and this is the one that has provided the standards for us. Okay, but then the underlying data standard is the fire data standard. Yes, some minor modifications have been done, but then if you really look at it, okay, there are hospitals here which are using a health locker. One, health lockers are nothing but storage providers, storage of health information providers in a very, very highly secured manner and very, very performant manner. So one set of hospitals and labs and clinics are using one health locker. The other set is using the other health locker. There are health information providers and there are health information users. And the centerpiece is the one that is facilitating communication between these disparate systems, okay, in a standard manner. So if you write your software to ABDM compatible protocols, then you should be able to access information and contribute information of a patient to any one of these repositories, to any one of these providers. Okay. However, you need the patient's consent, which is managed by this consent managers, which is also part of the gateway. Now, the government is also looking at how do we, create uh, more gateways, make it more democratized. Okay, so they are also looking at uh, creating private consent managers, creating private gateways, and how do they interact. Okay, that is still work in progress. So I'm just going to give you a little glimpse about what is fire, because there are other people that are going to talk about fire in much more detail. Okay, fire has got resources, and resources are grouped into resource categories. There are foundation category, there's a base category, there's a clinical, financial, and specialized categories are there. So in foundation, okay, all these are resources inside each of these categories. In base you have further subcategories, and then each category has got a resource. I mean, these are all in open source. You can go to fire.org and hl7.org, you will be able to see all of them. I'm just giving you a glimpse and an introduction to these standards, so that you are at least aware of these standards and aware of the parlance, and you can get much more information by going through the web, and you will be able to put things into context because you have already heard these terms. This is another set. Since I've run out of my time, it is running through pretty quickly. Okay, and this is just an example of how a fire resource looks like. Okay, as I told you, the biggest advantage is the ability to make sense just by looking at it. Uh, and then the fire also gives ability for you to intertwine structures. Okay, one resource can have another structures, and all these resources can be bundled into a bundle for communication. So it's a pretty well organized, and it has come from years and years of experience in the United States. So this, I think, is a good to go protocol. So the key learnings are, these. Interoperability standardizes communication between computer systems, and these are, basically the standards are enablers for interoperability. Okay, so it gives the advantage of freedom of choice, cost of advantage. The cost advantage is ability to digitally process information. That's a big advantage. And we have these standards that are predominantly in play today: HL7 CDA, SNOMED CT, LAW C, SNOMED CT for clinical terms, LAW C for lab results, ICD for disease codes, FIRE for communication, DICOM for imaging. Okay, so the Indian scene, the Indian Government National Health Authority has implemented a countrywide HIX called ABDM. They have also defined the protocols, and there are many software providers who are currently integrating their systems with the ABDM. So I've given you a couple of use cases. If any of you are architects, you can take some learnings from the architectural perspective. They are not in detail, but however, it gives you a good overview of what are the things that we are facing in the market today.